This is Daybreak, and thanks for staying with us. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. On my far right is Dr. Evans Kamuri, who is the Chief Executive Officer of the Kenyatta National Hospital. Good morning, Dr.
Morning, Ayub.
Lovely having you here on the broadcast.
Thank you. Thank you very much.
Good time to discuss healthcare. Dr. Brian Lishenga, on my immediate right, is the chairperson, the Kenya Rural Urban Hospitals Association of Kenya. Good morning, Dr.
Morning, Ayub.
Much appreciated.
Thank you.
And thanks for making time for the broadcast. Dr. Philip Kirwa is the Chief Executive Officer of the Moi Teaching and Referral Hospital. Good morning, Dr.
Good morning, Ayub.
Good to have you here on the broadcast.
Pleasure.
As well as Dr. Richard Lesiampe, the CEO of the Jaramogi Oginga Odinga Teaching and Referral Hospital. Good morning, Dr.
Good morning, Ayub.
Lovely having you here on the broadcast. Gentlemen, much appreciated. Your presence here is highly valued. And to discuss here the state of referrals, and I'm sure you are in the eye of the storm, given the number of referrals that you get at your respective facilities. But first, coming to you, Dr. Kamuri, tell us, in the midst of the transition to the new health system, that is the Social Health Authority, how has been the transition at the biggest referral hospital or facility in the country?
Thank you, Ayub. First, I would start by saying that the transition has taken place from 1st of October. And the first thing was to cross from NHIF to SHA. Yeah. The initial was a challenge. As you heard, everybody was complaining and things were not working. But the truth of the matter is, every start must have some hiccups here and there, especially when it's a system issue. What we did, like I will tell you, when we are transiting, there was a problem about crossing over from SHA to NHIF. But
from NHIF to SHA? From NHIF to SHA.
But what we did at that moment, at that particular time, we actually saw all the patients. We agreed, we had a crisis meeting, we had a PS joining us, and we agreed nobody will be denied services at that point in time. But you know, people kept on saying, oh, we are being denied, but the truth of the matter, we did not deny. There has been a few challenges here and there. Of course, the integration of the system. But I'm happy to say, Kenyatta, we were the first one to actually try the crossing over. We actually called the whole team. We called the whole team of SHA. We called my system, people in my system, the automation system, and we were able to integrate the system. At the moment, I can tell you, Ayub, now it is running efficiently. The transition has taken place, and we have now started delivering services as expected. Of course, as we say, there is always something, and I will tell you, I know you are not you are Muslim, but as far as Christians are concerned, if you read Hosea 4 verses 6, it says people perish because of lack of information, lack of knowledge, and people have refused to take the knowledge. We are telling people that now SHA is here. People must register. People must start being counted. And if you watched what we did yesterday, what was discussed yesterday, even by some of my patients, the people who have now tested the system are really happy about it. It has now helped us in terms of time, turnover, and the time between somebody registering, somebody starting being given services has actually, the time has really shortened quite a lot. So in terms of efficiency, we can say now that the system has started being efficient, and we are giving services faster than previously. So transition has its own challenges, has its own hiccups here and there, but the truth of the matter is, at the moment as we talk, 1 month, this is the 36th day, we can tell you now, it is now working, it's better, as compared to NHIF, which has taken several years. But if you count what we have achieved in the last 35 days since when we switched, we can tell you that actually.
So you have explained the system challenges. Then how about the people challenges who went there, and especially those who are suffering from chronic illnesses, dialysis, and who need chemotherapy sessions, and who have experienced delays in terms of the new healthcare scheme paying for their medical attention, and who have either not gotten services or the services were delayed?
Now, there are two things here we must separate. First, in terms of the patient who came for services, no patient was denied services. That's the first thing. And we were there, we have ensured that no patient was denied services. Two things, is it the system or is it the equipment? Now, two things have happened with SHA. Initially, we used to write a claim, pre-authorization, we ask, they reply, and we now, once they approve the other side, we start the services. At the moment, we are doing the other way around. The moment you are registered, we know what package you are entitled to, what you are supposed to be given. We start the services. It is like fit for service. We now start to use the services. We now send claim when the services have already started. And even if you go, and I would want people to go and ask the people who are receiving the services, even oncology, even dialysis, as long as you are in the system, we actually start the services, then it is us who claim to the SHA, not the way we used to do earlier. Initially we used to do a pre-authorization, it's approved, but this time we are starting the services, then we claim. So if you look at that, it has taken, and if you listen to one of the renal patients yesterday, he was saying the process takes 5 to 10 minutes. In 5 to 10 minutes, the services have already started. The challenges we have been having in renal is actually not the SHA problem. It has been the equipment. And you saw Waziri yesterday, visiting us yesterday.
Yes.
And affirming that the challenges have been the equipment, the dialysis machine. The machines that we have been having were previously from the MES system, which have, for us, because we do 24 hours, they outlived their lifetime. Their lifespan for those equipment, unlike other places who are benefiting from MES. For Kenyatta, we were doing, instead of 2 sessions, we are doing 3 sessions in a day. So the machines, most of the machines actually went down. They have outlived their
So how many dialysis machines do we have at the biggest referral hospital in the country? At
the moment, we have 6 machines, and we have been having like 20 or something like that. But what we have been happening now, we are in the process of acquiring a new set of machines, because, as I've said, the other ones have they have outlived their time. We are in the process of installing new ones. So, but in the meantime, you heard Waziri saying we have discussed with IACI. We'll have some machines from IACI to come and be installed while we wait for the process of procuring new machines.
All right.
So what I'm saying, the problem has not been the system, the SHA system. The ones who have been having the dialysis have continued, although now with the challenge of fewer machines.
So how many patients do you see for dialysis, say, or who have renal diseases?
On normal circumstances, previously before the break of machines, we see around in a day, that's for our day is 24 hours, because the outpatients we dialyze during the day, and the inpatients we do at night. So we do like close to 60 or 30, between 40 and 50 patients in a day. But at the moment, the numbers have come down, and that's why you will hear some people complaining because of the availability of machines.
We'll talk about the machines, because there was also a report by the Parliamentary Health Committee in 2019, which had extensively looked at all the referral hospitals, and we'll be discussing that. Dr. Lisiampe, how is the situation at the Jaramogi Oginga Odinga Teaching and Referral Hospital?
Yeah, thank you very much, Ayub. What I can say is that on the onset of SHA, that was effective 1st of October, the initial 2-3 days, we had challenges. We had challenges in the sense that, one, some of our patients had difficulties in registering themselves. We also had challenges in the sense that, one, we only got one gadget, to register these patients. And 3, we also had patients, who were not registered under NHIF in the past, and now they wanted actually to transit to SHA. And it became a challenge because some of them did not even have IDs, identification cards. So from day one, we had those challenges. However, I think progressively, we actually got interventions from SHA. We also had a few staff who had already been trained. And I want to just echo what Dr. Kamuria said. I think what is very, very critical about transition and change is the mental preparedness. And for us as JOTRH, what we have done was that we took the advantage of seeing to it that we become the first movers and take advantage of the first movers. You know, take advantage of adapters, fast adapters. And what I mean here is that we had already prepared our staff, in fact, from 1st of July, that we're going to have a change, you know, from NHIF to SHA. And we actually went ahead even to establish a department called the SHA Coordination Unit. And even went ahead to actually establish, you know, a committee to manage the transition into SHA. But notwithstanding that, we managed to get some of those challenges on day one, and I think also on day two. We also experienced challenges on network, you know, network downtime. You know, those are some of the challenges. However, what I can say is that progressively, some of these challenges have now been resolved. In fact, I think before I even go into that, we also had challenges in pre-authorization. In fact, the first 2-3 days, pre-authorization for patients to be admitted, you know, in wards. We also had a few patients, you know, who had already been admitted through NHIF, and on discharge, it was actually a challenge. The system could not actually discharge them. However, what I can say is that we have come out of that, and as we speak now, in fact, we are very excited, you know, in terms of the time taken to pre-authorize, you know, patients for treatment.
Okay.
Yeah. So we are also very excited that, you know, it takes 3 minutes actually to pre-authorize a patient to be admitted. You know, similarly, I think when it comes to issues of dialysis and I think chemotherapy, we had clear instructions and I think even clear support from SHA from day one that these are patients who are facing, you know, life-threatening conditions, and therefore we were to do everything possible to ensure that we transit them, you know, and ensure that they actually get this medication.
And then, in that regard, then the challenges, of the system that you appreciate. What then happens during that process? How about the out-of-pocket expenditure for Kenyans who are unable to pay for these services and who may not have the cash or be in a position to financially get that medical attention in the process of the challenges?
Yeah. One thing I can say, Ayub, is that we also have a policy on management of indigents. You know, these are Kenyans probably who cannot actually afford. Yeah. And what happens is that even in the past, we used to provide treatment, you know, allow them access treatment, and, you know, we carry the cost even as an hospital or as a government. We are lucky now that with SHA, these individuals, as long as they can actually register, you know, to become members of SHA, we will actually get reimbursements. And I think that's why I actually mentioned, I think in the past, that the challenges we have been experiencing as national referral facilities are those patients we treat, you know, they consume our commodities, you know, our specialists, you know, handle them and restore them to health. And then on discharge, they cannot actually pay. And sometimes we're even forced to hold them, you know, for a day or two or even for a week. But now with SHA, the fact that, you know, they were pre-authorized, you know, they are registered. In fact, we have no issue of, in fact, actually having anybody remaining behind in the hospital.
Okay. We'll talk about the means testing, because that's also a matter that the CS had explained when she appeared before the Health Committee of the National Assembly, chaired by Dr. Robert Pukose. Dr. Kirwa, then how does this all come down to the provision of a dignified care for patients? Ideally, all this is meant to have a convergence point of Kenyans getting affordable and quality healthcare.
Yeah, thank you very much, Ayub. So for us, first, we wanted to say that we really embraced SHA from the day one, because it's a game changer for us. We know that most of a large number of our patients, usually about a third, are actually not able to pay and won't pay. And are the patients who, at the end of the day, you would actually end up waiving. And therefore, for us, for this, for SHA, at the moment, we know that it will make a major impact in society, because everybody has access to healthcare, irrespective of whether you have money or not. And for example, for those patients who come in unconscious, patients who have had accidents, real emergencies, we do treat them, and irrespective of whatever means of payment that they will have. But we know that from SHA, that these patients will be managed through the ECCIF fund, And therefore, it actually gives us dignity and also the respect of a human being, and ensuring that they get the services as appropriate without having to look and ask whether they have an ID, whether they have money, where they come from, and who they are.
Yeah. And then how then do you account? Because there are many cases where we have patients who went to hospital. Let's say, for example, Salome Kamau, who is a patient, and she went to the Kenyatta National Hospital. Chronic kidney disease is what she was suffering from. And to quote her, she said, this is in relation to under NHIF dealing with chronic kidney disease is my case. Was much more manageable compared to the current predicament. NHIF used to deduct 8,500 shillings from my cover for each dialysis session because I need 2 per week, but now I'm compelled to pay 11,000 out of pocket every week just to stay alive. Are these real day-to-day challenges that you face from patients at Moi Teaching and Referral Hospital?
Yeah, thank you. So for patients who come in for dialysis, when they are registered previously for NHIF, from day one, all of them were receiving appropriate service. So they got their dialysis because they had a cover. Even after the registration into SHA, as it is now, all the patients have actually been receiving care because they have a cover. Once they have registered with SHA, nobody has been denied a service. And I don't think anybody's deducted money or asked to pay money extra out of their pocket. Sometimes maybe I would just say there might be a confusion because occasionally patients who are in NHI previously, and when they're done transition to SHA, they're done a mean testing. When they're done a mean testing, they'll be given a new figure. So they actually top up the difference of what they are paying and what they're due to pay this moment. And that probably gives an impression that probably somebody's charging them, but truly it's not a charge. Nobody's being charged. The second thing that I wanted to say is that for patients who are not previously even registered for SHA, once they come in and they register, once they come in for service, and even if they had money and they wanted to pay for the service, we would ask them that probably register first for SHA and pay for SHA, and then you get the service. In that way, it means you've actually ensured that this person is going to be able to receive services for the rest of the year, unlike when they come in for that, pay for that service for that point only. And it's almost the same amount of money. So we really encourage that patients, when they go to hospitals, let them not go and pay for out of pocket for the service. Let them go register and pay for SHA and get the service, because it's instant pre-authorization. Okay,
how much is the allocation under the Social Health Authority for people who are suffering from chronic kidney disease, for example?
For chronic kidney disease, it's per session, it's 10,650 every session.
Yeah, 10,650.
Yeah.
So that's more than what NHIF had allocated.
Which was 9,600.
9,600.
Yeah.
All right. Then, is this then a working system where when these patients come for dialysis, say, then yes, the allocation under SHA is improved, but are they getting the services on time? You're handling someone suffering from chronic disease like kidney disease.
Yeah, thank you very much. Now, when you look first at the compensation that is in SHA, for hospital, it's actually a plus, and it's a plus a lot, because across all services, the hospitals are compensated more. That means we're going to have more funds to be able to invest into healthcare, improve equipment, improve the environment, improve on the personnel by more training, etc., and also recruit. And therefore, when you look across board for the hospitals, it's actually a plus for us. And you've mentioned one, for example, is the kidney dialysis. And therefore, going forward, it actually for hospitals and for healthcare generally, it will be a much improved service, despite the challenges that we've just had recently. But I think as we go forward, we keep solving them, because nothing comes without challenges.
Yeah, okay. Yeah. So we welcome the contributions by members of the public watching this broadcast from across the country, and the three doctors will be responding to your questions, and where you need clarity or more emphasis on the set of referrals and the institutions that they had. Yes, Dr. Brian Lishenga.
Well, thank you. I will play the devil's advocate in the morning. Given that I don't run a referral hospital, but I think that my colleagues are rightly taking a very optimistic view of the situation. We, as representatives of the private sector have, we share some of the experiences, but we also have differences. I would want to be honest and say, and this is aimed at those who are managing the transition, that Kenyans are having extreme difficulty. It is hard out there. We had a survey running within our healthcare system from 28th to 31st of October, and we found out that 87% of healthcare providers were telling us that they are having trouble authenticating and verifying beneficiaries. And some of the commonest challenges that we saw is missing dependents, for instance. You come to hospital, your daughter or your son, whoever, dependent goes in, and the details are not there. Another challenge that we have seen, and these are the reasons why you hear so much public outcry. Another challenge that we have seen is especially those who had made contributions in advance. We had been told that if you paid for your NHIF subscriptions 1 year, 2 years in advance, all that amount of money you pay will be transferred seamlessly to SHA. Yeah. What we are experiencing on the ground rather is opposite, because those particular patients who had paid in advance, in some cases, actually in most cases, we are not able to trace their contribution history. So if I log into the SHA portal today, I cannot tell that Dr. Kiro had paid 2 years in advance because I cannot see his contribution history. What I can only see is either he's eligible or not eligible. And we have this kind of problems, OTP delays. What my colleagues are not talking about, when you want to pre-authorize a case, there must be a one-time PIN sent to a phone. Now, we have seen one technical issue is OTPs delay to be sent, sometimes 30 minutes, 2 hours, 3 hours. You're waiting for the one-time PIN to come in so that you can proceed to the next step. Sometimes with the very elderly patients, who, they gave the phone number of the daughter, the son, whoever. That phone number is somewhere else. And even in very conservative societies, you have the main phone number is the husband's number. Who works in Garissa, the family is in Kakamega. Now, in that case, you're going to wait for the gentleman to get OTP and send for the care. So we have real challenges. I would even mention something about pre-authorization that my senior colleagues here are talking about pre-authorization being seamless. In the seamlessness of pre-authorization is where there is a problem, because we did a very quick run and we found out that if you pre-authorize any amount of money for any procedure, it will be accepted. So let's say you want to do a simple procedure like a cesarean section, and it's 32,000 now, and your clerk by mistake adds an extra zero and becomes 320,000. The system accepts. Now, we are concerned as healthcare providers that 90 days from now, when those claims become payable, we will go into adjudication issues and audits. Because now we will be saying, hospital will be saying, my portal says you owe me 13 million. NHIF is saying, no, we owe you 1.3 million. And the reason we are pointing out the challenges in the system so that the system can be improved fast enough. Yeah, so, and this, to be clear, Dr. this is the system that was meant to have been set up by 104 billion Kenya shillings? I cannot. It's very difficult for me to speak around the politics of that. But I would tell you. The point is, it's value for money, because yes, it's in the. You all agree with me as professional doctors that when we talk about the value for money, it's the taxpayer watching this broadcast who all come to your facilities and seek medical attention, a majority of who cannot pay or afford out of the pocket expenditure they're incurring at the moment. The point I'm making then is, how do we remedy that situation of the system inadequacy and clearly the very dysfunctionality that you have pointed out? Let me be blunt and say, I think that there are two different aspects here. There is the SHA portal, which is being run by a local company, which we have been interacting with, the Savannah Informatics. They are doing a great job trying to turn around a system very fast. In fact, I would say they have outdone themselves. That is one side of the story. So despite the challenges that we are seeing with the SHA portal that I have described, I think I think in the next 1 month to 45 days, Savannah Informatics will be able to give us a stable portal. But that is one side. There's another side called administration or ERP side of SHA. Now, this is where SHA itself as an organization is supposed to have a dashboard where it checks who has paid what, contributions, who is an eligible member, you know, how it manages it. That is missing. And that component of the ERP, the SHA ERP, is the investment that was supposed to come from the consortium. So the consortium was supposed to put in money so that you create the digital health superhighway, you create the health information exchange to enable referrals to them. Let me explain something. Today, if I want to refer a patient to KNH, I am referring with a piece of paper. We were promised that these referrals will be digital seamless, so that if I am sending a patient for an eye procedure, an ENT procedure, they don't carry a piece of paper. The challenge we are going to have is this: is that piece of paper contractually admissible? Because remember now, we have said that you cannot walk straight to KNH or to MTRH as an outpatient case. So if I have an eye problem, if I have an ENT problem and I want to go to Jute RH in Kisumu, I have to go to a level 2 or level 3 facility. They write me, they see me, then they send me to Jute. Now, the problem is that paper can be generated on River Road. You know, I can go somewhere and somebody will write a letter, and it is a referral note. We are saying that the investments that we were promised to have a functioning referral system need to happen.
Thank you. When we get back from the break, Dr. Kamuri, I'll begin with you as we expound on this, because it all again boils down to the state of equipment, because the report done by the National Assembly's Health Committee in 2019 pointed out in all referral hospitals the challenges and some of the submissions made by the management of the respective referral hospitals across the country. And we welcome your contributions as well here on the broadcast. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. We are back with more after the break here with the doctors. Stay with us.